Good afternoon. My name is Stephen Peeler. I'm the Executive Director of the Infectious Disease Society of America Foundation. Today, I'm happy to welcome you to our talk, HIV Speaks, History, Healing, and Hope. This is the second webinar as a part of our John G. Bartlett Education Series. This series is a collection of infectious disease lectures from industry experts and patients, as well as other subject matter experts in our field. We will have pre-recorded videos from Dr. Bartlett himself for some of our upcoming events. These lectures honor the groundbreaking work and thought leadership of Dr. Bartlett. He was a pioneer in infectious diseases whose mentorship inspired many. On behalf of all of us at the IDSA Foundation, we'd like to extend a sincere welcome to our presenters today who volunteered their time to speak about HIV research and their personal experience with the disease. We're grateful to have their support in this exciting event. And to those of you watching, we want to thank you as well. We hope that this talk will create positive impact in the work of HIV, prevention, and patient care. As you may know, December is HIV/AIDS Awareness Month, and it brings together the attention to a disease that has affected many people around the world, as well as, of course, the United States. For more than 40 years, through this event, we will bring new insights to the table through the perspective of our experts in the field, as well as those who have experienced the disease firsthand. This John Bartlett Education Series has been brought to us and to you today with the generous support of an educational grant from Therapeutics. First, we would like to hear from Dr. Hewlett Jr., who will discuss the first identification of HIV in the United States more than 4 decades ago. He will provide insight into advancements in treatment that have dramatically improved the quality of life for those living with HIV. Dr. Hewlett.
Good afternoon, and it's an honor to be asked to take part in this program this afternoon, commemorating the 40th anniversary of HIV, and also importantly, commemorating the work of Dr. John G. Bartlett. We cannot mention HIV and talk about a commemoration in HIV without recognizing the great work that Dr. Bartlett did. When I was an ID fellow here in the Bronx, New York, back in the early 1980s, I remember being introduced to patients who had disorders that we could not figure out. And we later found that they actually had HIV. At that time, we didn't know the causative agent. However, very quickly, with the collaboration and cooperation of academic centers, researchers, the government, and commercial entities, we were able to determine that this was indeed a retrovirus that was causing this. And so by 1983, 1984, we knew that this was caused by HTLV3, as we called it then, and now we call it HIV. We found that there were a number of groups who were most impacted by this infection. We found that individuals who were gay, we found individuals who were using parenteral drugs, individuals who were recipients of transfusions, and infants who were born to mothers who might fall into certain risk categories. We were faced with a challenge. We didn't actually have a treatment. A very bright spot in my career occurred in 1994, when the drug AZT or zidovudine was discovered to have a beneficial impact in decreasing the mother-to-child transmission. And we worked as a team here in New York, and I'm sure the same occurred in other parts of the country, to try to mobilize and to put together an infrastructure in our public and private hospitals so that we would be able to make sure that all of the mothers who were HIV positive would receive treatment and that their newborns would also receive treatment. And we knew that this treatment would actually decrease the transmission of HIV by about 67%. When we look now specifically at Dr. Bartlett, and I think that it's important for us to look at Dr. Bartlett, not only for the work that he did in HIV while he was at Johns Hopkins, but also for his vision, because his vision, I think, will lay the groundwork for us in the field of infectious diseases as we approach future challenges. You may not be aware of this, but in 2008, Dr. Bartlett and his colleague, Dr. Borio, wrote a position paper, and it was entitled "The Current Status of Planning for Pandemics." And he basically stated that the US needs to be better prepared for a large-scale medical catastrophe, whether it would be a natural disaster, bioterrorism, or a pandemic. So he was predicting in 2008, almost 12 years to the day, what was going to be happening in 2020 when we are faced with COVID. And he basically stated that the harsh realities are that the US healthcare system is a private competitive system, it's broken, and it's working at capacity, so that any demand for surge cannot be met with the existing economic resources, hospital beds, manpower, or supplies. And that is the challenge that we are facing in infectious diseases today. Dr. Bartlett came to Johns Hopkins University School of Medicine in 1980, and he became the chief of infectious diseases there. And this was essentially the time when HIV was first starting to come on the scene. He devoted much of his 26-year career at Hopkins to HIV care, and he was very innovative. And if we look at that model that he put together when he started, there were 3 full-time faculty members at Johns Hopkins in the field, in the area of infectious diseases. And when he left in 2006, there were 55 full-time faculty members, and they were performing over 5,000 visits per year. He developed dedicated HIV services. He also developed HIV and hepatitis services, as well as services related to tuberculosis. So as we move forward, we are going to be facing challenges, and certainly in our field of infectious diseases, we are facing manpower challenges. It's up to us to follow in the footsteps of Dr. Bartlett as mentors and as teachers, as clinicians, and also as researchers in our field of infectious diseases. We've made great strides in this area, and you will hear more about that in just a moment. But we have gone from a disease that had no treatment back in the 1980s to a disease that became treatable and managed as a chronic disease to a disease now that we can actually prevent. And so I hope that you will be inspired from some of the information that is going to be shared with you later on in this program. So I'll turn it back over to our moderator. Thank you very much.
Thank you, Dr. Hewlett. Thank you for sharing your journey, as well as a little background on HIV, as well as Dr. Bartlett today. Right now, I'd like to turn the program over to Dr. Wafaa El-Sadr, and she will give you her perspective of the journey as well. Thank you.
Well, thank you very much. And I very much appreciate this opportunity to be with you all today, and particularly to continue to honor the legacy of Dr. John G. Bartlett, really a giant in our field, and somebody that many of us hold dear and revere, and have always revered and will continue to revere for the future. When I think back now on the 40th anniversary of the first US cases of AIDS that were identified at that point in time, and I think of what has evolved over the past more than 4 decades, I think I marvel at some of the advances that have been accomplished. But at the same time, we're celebrating these advances, I also have to reflect on some of the gaps that continue to remain. and some of the challenges that, that we also need to face today and as we move forward. Thinking back now 40 years ago, as Dr. Hewlett was saying, I was a young infectious disease attending physician then in New York City as well, in the Harlem community. And I think what I recall are many years, months and years of intense pain and suffering and frustration. I think for many of us, we felt in many ways, in a way helpless in many ways, because we had so little to offer to our patients beyond offering the support and the care and that they needed at that point in time, and also to offer them the support they needed to deal with some of the enormous stigma and discrimination they faced in their day-to-day life. These were not easy years. These were very difficult and painful years that were experienced by people living with HIV and also by people who took care of people living with HIV. I think importantly, I think also to recognize that I'm very proud that the infectious disease community of physicians and trainees was the community that really stood up and rose to the occasion and took on the task of taking care of people living with HIV during this very difficult times. There were many others in the medical profession who ran away from HIV and people living with HIV, but I have to say that it was our community of infectious disease specialists and trainees that ran towards these patients, doing everything they could to allay their suffering and to support them during most difficult times. However, I think what also evolved and I think has been inspiring are the major advances that have occurred. Firstly, in terms of diagnosis of HIV, the availability of testing to be able to detect people living with HIV, as well as the evolution of treatment, effective treatment for HIV. And again, this was a gradual process with many of us remembering patients having to take a large handful of doses of medications 4 times a day sometimes to be able to achieve the benefit from these medications. And however, we moved on to a point in time where now individuals living with HIV can take 1 pill a day, and that can transform their health and well-being. Dr. John G. Bartlett was instrumental in making these advances, both in terms of the discovery of these regimens, the treatment regimens, but also in his critical role in the guidelines, the developing guidelines that really helped us all as practitioners to do the right thing. And that's been very critically important, is that he was so astute at helping craft guidelines that made sense, that all of us could look at, could use, synthesize the most recent evidence that was available and give us a step-by-step guidance in terms of what to do as we took care of our patients. And that's a legacy that is durable and continues still today with the guidelines that we have available nationally now. As we moved over time, I think the epidemic also evolved and beyond affecting the high-resource countries like the US and moved to a massive global pandemic that still goes on to this day. Even in the context of the COVID-19 pandemic, we still have a very much an HIV pandemic that's raging as well. So we have now a moment in history when there's a collision between these 2 pandemics. And I think in many ways, again, the lessons we learned here in tackling HIV and responding to the needs of people living with HIV in this country were very informative to me personally and to many of the people I worked with in shaping how we could also bring some of these advances to some of the millions and millions of people who were living with HIV in other less fortunate contexts. Whether these less fortunate contexts were right here in our communities, in our own country, or whether they were in other countries around the world, including primarily in sub-Saharan Africa. And I have to say that the guidelines that were developed and the knowledge that was developed locally was incredibly informative, and for us as we went to try to tailor these responses, adapt them to other contexts, and then to start to see and reap the benefits of treatment and notice these benefits and be able to celebrate those benefits for the millions of people living with HIV elsewhere. And for me personally, I've treasured the opportunity to work both locally and globally, still working here in Harlem and the Bronx, while at the same time also working in more than 30 countries around the world. I'm a believer in terms of how the local can inform the global, but also how the global learnings can also inform and inform our local response. And I think we have to continue this learning and this openness to taking innovations forward. And then I think I need to touch as well on the issue of prevention. It became very evident that while we have made massive advances in treatment, not for everyone, I'll talk about the gaps shortly, that we had to also focus on prevention, primary prevention. We know that treatment is prevention, and that's why it's critically important for people who are living with HIV to be aware of their status and to get on treatment and stay on effective treatment. But I think the next challenge that our community faces is the challenge of prevention. We've known that condoms are really effective at preventing sexual transmission. We also know that harm reduction is effective in prevention of transmission amongst people who inject drugs. But nonetheless, we know that there are lots of behavioral interventions that have been shown to work. But I think the real progress happened when the identification that treatment worked for prevention by decreasing the viral load, which is very important. But then the advances in primary prevention, and that I'm thinking of pre-exposure prophylaxis or PrEP, which enabled people who were not HIV infected, who were at risk, to be able to take a pill a day. And that pill, if it's taken according to prescription, then as prescribed, to prevent them from acquiring HIV. And that was a huge advance in our field. And even more recently, I think we've also identified now long-acting PrEP agents, injectable agents that hopefully can be maybe authorized soon or approved soon, that offer the opportunity of maybe one injection every 2 months that can be substantially protective to people from acquiring HIV. So I think the advances in both prevention as well as in treatment have been profound. And that is real cause for celebration. However, we also have to recognize that not everything is rosy, and we continue to see the impact of continued transmission of HIV in our own country, now affecting mainly subsets of our population, particularly men who have sex with men and other men who have sex with men, particularly persons of color, who at this point are bearing the brunt of new HIV infections, as well as also disproportionate impact on women of color in our own country. We continue to see also globally large numbers. Now it's estimated that overall even today, there's about 1.7 new HIV infections every year. So we have a long way to go in terms of expanding both treatment as well as also expanding prevention. Now, you may say, well, we have the tools in our hand. Why are we not able to get to the end of AIDS, which is certainly our goal, to end AIDS as a global pandemic? And I think it's a realization that there really are no magic bullets. Is that biomedical interventions and biomedical discoveries are enormously, amazing advances and enormous progress that we are witnessing with the flourishing of these discoveries. But what we have to do is to think beyond that, to think about why are certain populations in our midst, whether they be in this country or around the world, why it has been difficult for them to gain access to these interventions. And some of it are issues that are structural, issues around structural racism, issues around discrimination. Some of them are issues around poverty, lack of information. Some of them are issues around denial and fear of stigma and discrimination. And that tells me that we should not rest on our laurels and think that we have a magic bullet. What we have to do is to take the tools we have identified and wrap around them the supportive kinds of interventions that allow for an integrated approach, that takes into account the priorities as well as the challenges that the people at risk for HIV and people living with HIV face day in, day out. And it is through this recognition that we don't have a magic bullet, that we have to continue to innovate, and we have to continue to adapt, and we have to continue to make our innovations, to make our discoveries accessible and available to the breadth of the populations that need them in exactly the manner that they need them. So I'm going to stop here and hand it back to, I'm not sure who I handed back to, but thank you for your attention.
I'll take it from here, Dr. El-Sadr. Thank you so much for your explanation of the innovative models that are being used today compared to in the past. Also talking about a multidisciplinary approach. I think that was very informative. Thank you very much. We definitely appreciate your work behind the scenes, as well as Dr. Hewlett in dealing with HIV and HIV patients. At this time, we'd like to hear from someone who has experience with the disease firsthand. I'd like to introduce you to Harold Scott, also known as Scottie, who is an HIV survivor of 30 years and a wonderful patient advocate. Scottie, I turn it over to you.
Thank you. As we've already heard, HIV/AIDS has been a part of our lives for the past 40 years, perhaps even longer. For me, I have personally lived with the virus for 32 of those years, almost half my life. The virus thought to only affect the larger cities of the United States.
There we are. All right, Scottie, we'll bring you back. I think that we had a great conversation with you to now. Dahl, would you like to start with some of what we could hear of Scottie, and then we'll bring him back, obviously. Maybe you two could talk about how obviously that was a very common situation, or a common way of acquiring the disease back in the day.
Yes, well, sure. What Mr. Scott was describing was pretty much what we were facing. That is, this was an unknown. Most people had not heard of this. A lot of the surveys showed that people who were outside of a few people who were in the larger cities, most people didn't know anything about this disease at that time. And so this was a fairly typical story. This was what I saw many times in my small practice in Yonkers, New York, and also we saw it many times at Lincoln Hospital in the Bronx, which was one of our public hospitals. And unfortunately, at that time, we did not have a lot that we could offer. However, we rapidly learned that this disease, when it was in its full manifestations, was complicated by infections, and we were able to, at least at that time, prevent many of the infections, which would put the patients in danger.
Mm-hmm. Mm-hmm. Anything to add there, Dr. El-Sadr? I think you're on mute.
Somebody's
Now
we can hear you.
Yeah.
Yes.
Yeah, I think when I think back, Dial, of those years, I think in many ways, and I don't know if you agree with this or not, is sometimes the lack of kind of a effective treatment, the lack of, some biomedical, at that time, effective antiretroviral therapy, I think transformed the practice of infectious disease. I think many of us really trained in infectious disease and thought of our future as being kind of more of the traditional hospital consultant type of infectious disease practice. Mm-hmm. And here we were almost overnight challenged with a whole other way of practicing our profession. We moved to becoming really primary care providers. for people living with HIV, because others did not feel like wanted to do this, or they didn't want to do it, or didn't know how to do it. And it created also, so we became more, rather than sort of more the episodic hospital infectious disease consultant services of the past. In addition to, of course, continuing to do that, we became also, we had to learn how to become effective primary care providers. And we had to learn, and we also had to learn how to work as a multidisciplinary team. This was a whole new way of practicing medicine. All of a sudden, we realized that it was, what we could do was only part of the answer, that we needed that social worker more than ever. We needed to have the nutritionists on our team. We needed to have the caseworkers. We needed to have the outreach workers. And it was a realization that there's beauty in medicine that goes beyond kind of the limited practice that we anticipated, that it forced us to establish these very deep relationships with our patients, not just as individuals, often with these patients and their families and their loved ones. And we became a team taking care of families and beyond the individual patient sitting in front of us. And I feel that that was a very critical transformation of the practice of infectious disease.
I totally agree. And this was something that all of us experienced. And I like to tell some of our colleagues who are coming into practice, and it's not specifically related to infectious diseases, that we have to always think about the role of the physician. And Dr. Trudeau expressed this very well many, many years ago when he said, and I can't quote it exactly, but the role of the physician is cure occasionally, improvement often, and comfort always. And so we should always be able to comfort the patient, even though we might not be able to improve their condition, or even though we might not be able to cure it. And I think over the years, we actually witnessed a change in our role, so that we got to the point where we were able to at least control, and we like to say cure, the disease in most of our patients.
Thank you both. I believe we have Scottie back. Let's hope his sound is a little better. We'll go ahead and mute. We'll check and see if he's back online now. He's still having a little trouble. All right, so no worries. We will continue with Dial and Wafaa.
One of the things I will ask Dr. El-Sadr to comment on. You mentioned needing support, and I think that in the hospitals at that time, our city hospitals, we had, as a result of the work of Dr. Bartlett and others, there were new modalities that were coming onto the scene. And in order to use these new modalities, we had to actually fill out usually reams and reams of paperwork. And we actually lacked support. And many times we were reluctant to use some of these new modalities because we didn't think that we would be able to finish all of the paperwork and at the same time take care of all our patients. And maybe you could comment on that, because I know that you did that very, very well at Harlem Hospital.
Yeah, I mean, I think, and that's where having a team made a difference. I mean, you recall that in those years we all of us at the city hospitals here, I was at Harlem, you were at Lincoln, developed these multidisciplinary teams that then sort of took care of all the patients in the hospital. And we have these weekly meetings and we go through patient by patient and identify how they were doing, but more than this, what else did they need? And it was so fundamentally important to have sitting around the table the amazing caseworker, the remarkable family counselor, and I think in many ways it was what I felt and I continue to feel is that there was this and continues the enduring passion in terms of a commitment to doing whatever it took, to be able to bring the comfort, to bring the services to these patients and their families. And it was also a realization And that was both inpatient and outpatient. And the realization that dawned on me early on was that we had to reach beyond the walls of hospitals and clinics. And that's probably was a very important early lesson I learned that has guided my work globally as well, is that we often think is that, you know, sitting in a clinic or sitting in a hospital and we await whoever comes to us. It's a rather very passive way of thinking about care. And it obviously means that we will always be restricted to seeing the tip of the iceberg, the people who found us, you know, and either they came to us because they got sick, or they came to us because they utilized one of the services and then they continued with us. But that is just the tip of the iceberg. And I think we realize that if we just focus on this tip of the iceberg, we'll be missing the rest of the iceberg. Then that's when the whole partnership with community organizations began. And this the engagement of people living with HIV as peer educators who could reach out to other people in the community because they had the trust of these people and talk to them about HIV and the importance of getting tested and tell them about the services we had. And that allowed us to go beyond the tip of the iceberg to think about what else is happening in the community. And it was an important lesson learned in terms of reaching behind the constraints of the walls of our hospitals and clinics.
Yes.
And I think those and that, I mean, if I think of some of the enduring lessons from HIV is that we all, if I can, maybe I'll start counting them and then Dr. Hewlett, you can add, but I would say learning to be humble as a physician, you know, you are part of a team, learning to develop multidisciplinary team and respect and value the work of a team. I think number 3 is learning to go beyond the walls of our clinics and hospitals. And probably number 4 is the amazing value of people living with HIV and their commitment, and organizations that cater to people living with HIV.
Yeah. One of the things I think that is amazing about HIV right now is that if we look at the practice as it exists today, it has gone from where we were in the late 1980s and 1990s to a practice in which it's almost pharmacology, advanced pharmacology, where now all of the emphasis is on trying to design regimens for patients that will match with their underlying disease. So as Dr. Bartlett was engaged in hepatitis C co-infection and HIV, and then looking at tuberculosis patients and HIV. Certainly in the area of prevention, we have to look at all of the underlying disorders that people have. And so it's a totally different situation. And I think that we are all very, very glad, and I'm certainly humbled when I look at all of these advances, because I realize that it takes a special type of physician with a special type of skill to actually practice HIV medicine. It is really just quite a complex kind of an endeavor.
I mean, absolutely. I'm sorry.
No worries. Go ahead. Sure.
Absolutely, I agree with you, but I sometimes worry that, you know, it's true, and the treatment has become so sophisticated, and like you said, the pharmacology and shaping regimens and so on is so important at this point in time. But I worry sometimes that we're again focusing on the tip of the iceberg. We know that, you know, in our communities, people are, and you know this, I'm sure, is that people are still acquiring HIV. We know that sometimes we get those patients who come in with very advanced HIV. Which is tragic in this day and age. And we have to ask ourselves, why is that happening? Why are people not, you know, even though they are at risk and they probably appreciate at some point, to some extent that they're at risk, they're reluctant to get tested, they're fearful, they're afraid of the stigma, they're afraid, you know, and they're in denial. And we kind of have to continue to chip away at all of these impediments to get to people who still are acquiring HIV and are not benefiting from all these prevention great tools we talked about, as well as people who have living with HIV but just are reluctant or afraid or don't know where to go. And so I feel like that even though we've become very sophisticated, we need to remember that we're still dealing, if we just focus on this, that is the tip of the iceberg.
Yes.
Very good. Before we get to some of our panelists' questions for both of you from our audience, I wanted to ask you to, you mentioned healthcare disparities and how it's hurting some of the specific communities that you're working within in an urban setting there. Can you, both of you, talk briefly about how healthcare disparities is still evident in HIV treatment of your patients?
Please go ahead first. Yeah.
Okay, I can speak certainly from the role we have here in a health department. The Westchester County Department of Health actually, we have about 1 million people here in Westchester, and we border the Bronx, and we have a large population of underserved individuals in many of our communities. One of the things that we're struggling with right now, and were it not for our full engagement with the COVID outbreak, we have been tasked with trying to increase the utilization of our AIDS prevention program. There's an underutilization of these services. With our health department, we actually are offering medications free of charge, but many people still need to be educated. As Dr. El-Sadr was saying, we need to be out in the community. We need to be doing more outreach so that we make people aware of the importance of diagnosis and also not only treatment, but also prevention. And I think a lot of people are not aware of the services that we have. Fortunately, we have received a grant from U.S. Health and Human Services, which is devoted to enhancing health literacy. And part of that is to educate people about diseases, not only COVID and the vaccine, but also about HIV, how it can be prevented in some of the services which we have. And so I think that that's one of our big concerns, and it's going to be an area of focus for us. And certainly we need as much help as we can get in terms of getting out there and educating the various segments of our community here in Westchester.
Thank you. Wafaa, would you like to add to that?
Yeah, I mean, I agree completely, and literacy is very, very critical, and I think similar. I mean, it's the same lessons we're learning with COVID-19 is engaging with civil society groups and community groups in partnership, because sometimes they can actually reach where we cannot reach. They're often trusted by the communities themselves. They can translate what we're saying into probably much more coherent language and accessible language. So I think if we are to focus on really getting or garnering the benefits of all these amazing discoveries, these partnerships become so vitally important to get to the next stage.
Thank you. We do have a question from the audience. It is, can you comment on the similarity of the onset of COVID pandemic to the early years of HIV?
I'll start on that one. Yeah, I mean, there are lots of similarities. I would say, I think number one is who has been most severely affected. I mean, HIV affected the most vulnerable, the most disenfranchised in our communities, and similarly, COVID-19, of course, shined the light on these same disparities. We know when you look at the effect on COVID-19 SARS-CoV-2 infections is that what we've noticed is, for example, African Americans tend to have much worse outcomes than others. We've noticed that, again, if you look at outcomes, it's very much depends on how well, if you have a comorbid conditions, how well that's controlled. And we know that in some of our communities, because of the quality of the services they have available to them, or because of access issues, is that often these chronic conditions are not well managed, and that makes them more vulnerable. So both HIV and COVID-19 in some ways shine the light on the vulnerabilities in our societies and the disparities in our societies. So I think that's a big issue. I would say the second one is learning again the lesson of involvement, importance of involving communities. And it took us a while in HIV. It didn't happen instantaneously. Remember, advocates had to bang on the doors, to be heard and to be respected. And with the COVID response, we saw similarly. We were everybody was, wondering, why aren't people getting tested? Why are people hesitant to get vaccinated? And, it's all about trust. It's all about working with the communities, listening to them, and engaging them, engaging their champions, engaging their advocates. So I think that's kind of another lesson that's in a similarity I find between HIV and COVID-19. I think maybe a third aspect is obviously the pace of advances, and that's been very dramatic in terms of COVID-19. When you contrast that with advances in HIV, we often hold up HIV as a field where advances were happening at a rapid pace. But again, when you contrast that with what's happening in COVID, the pace is much more rapid in COVID-19. And people ask me, why is that the case? Of course, it's the biology of the virus itself, and the ease of creating a new vaccine versus the struggles we've had to get a vaccine for HIV. But sometimes people also will say, is it because COVID-19 can affect everybody versus HIV affected some? And whether that in some way also implicitly drove the willingness to put in the resources and so on into tackling COVID versus HIV. Dial?
Thank you. Dial?
Yeah, I would mention, I would agree with everything that Wafaa has said. One of the other places where I think there is a striking similarity is the segments of our population who are unwilling to accept treatment. And early on, certain segments of our population, even though we had treatment available, were unwilling to accept that treatment. The same is true for services related to prevention. And if we look at COVID, we have a similar situation where we have a segment of our population that are unwilling to accept vaccination. And so we have to work very hard to figure out how we're going to get to that segment. One of the other things which I think is a parallel with HIV and also with COVID is the fueling of the pandemic in both cases by mass incarceration. And so we know that a lot of people come out of our correctional facilities and they bring HIV back to the community. And the same has been true with COVID. The main difference has been the rapidity with which infection has been spread, but the end result can be equally devastating. And so these are things that we have to work on very, 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 very hard over the next several months and years.
Very good point.
Thank you. We have another question here. This one is from Doctor. Patients of mine refer to lots of similarities, especially in the sentence of death. Can you speak to this? I think they're talking about the similarities between COVID and HIV. And this is from Dr. Maria Claudia Stockler de Almeida. Sentence of death.
I'll say one thing, and just very briefly. I think that now most of us feel that if we are able to catch the patients early enough with HIV, then this is no longer a death sentence as it was back in the early 1980s when we were seeing the people at the tip of the iceberg who were the sickest people who we couldn't really help. Now, if people are diagnosed early and if they avail themselves to treatment, we can successfully manage them. With COVID, we do have a similar situation. If people take the vaccine, they are not going to get seriously ill most of the time, and they can be prevented from dying even if they have more underlying morbidities. We know that we're starting to see a lot of breakthrough infections now with the Omicron variant, but fortunately, we're not seeing people who have been fully vaccinated. We're not seeing these people dying. So we are seeing the death sentence, but it has been confined to those individuals who have decided for whatever reason that they don't want to be vaccinated.
Yes, absolutely. And just to add as well, maybe the relevance of early diagnosis applies to both. Clearly, it's tragic when we get that patient with HIV who comes in with cryptococcal meningitis or evidence of advanced disease, and that urges us as much as possible to do this work to be able to get people to get tested and frequently tested if they are at risk for HIV. And it's similar for COVID. I think we're beginning to see an evolution now is that early diagnosis, so people who have symptoms, again, the use of testing is very important. And early diagnosis offers people the opportunity to also get now some of the treatments that are available. Because as we know that now the evidence shows that for several treatments, whether they be monoclonal antibodies or some of the new antivirals that look promising, is that the earlier that you get treated, the better your outcome is going to be. So that's kind of another similarity between HIV and COVID, and therefore it does not need to obviously be a death sentence.
Right. Thank you. The next question we have is from Dr. Olade Akande. Question on top of my mind today is how to help a segment of the population who refuse treatment. Can the panelists share any best strategies to help patients who refuse ARVs, antiretrovirals?
This has always been difficult. I can just share with you my experiences, which when I had a part-time practice and also in the hospital, when we were treating HIV patients, I would try to understand exactly what the person's concerns were about treatment and try to explain to them the benefits of treatment. I would basically try to tell them that if they were my sister or my brother or my uncle or my aunt, that I would recommend that they be treated. That would be the kind of recommendation that I would give to them. But I would try to make sure that I addressed all of the questions and concerns that they had. I would try to avoid at all costs being in any way judgmental. I would try to understand why it was that they didn't feel that they should take the treatment. And I would just try my best to give them as much objective information as possible. Sometimes this would work, other times it wouldn't. Sometimes getting the trusted messenger involved, another person who might be under treatment, to have them talk with that person. And this is where some of the group sessions are an advantage, where the doctors may not be able to convince another person, but someone who is from their community, who they trust, who is also on treatment, that can sometimes be very helpful.
Yeah, I agree with them. It's kind of, that question is always reminds me of the question I'm asked every day now is how do you convince somebody who's refusing vaccines to get vaccinated? And because the response is quite similar. There is no magic one sentence or something that will work for everybody. And as Bayer was saying, it requires listening very carefully to why is the person refusing treatment or refusing a vaccine. and trying to, respond, give them the information back if they have misinformation or disinformation, to give them the right information. It also means being relentless, never giving up. Because it's, I'm sure, Violet, you've had the same experience where we
Yes.
struggled with patient after, where I remember vividly a woman that I took care of who for years, as I watched her develop progressive HIV tragically. And then it's kind of was actually the nurse in the clinic who convinced her. It wasn't me. It was a nurse who, she developed a close relationship with, that was able to convince her. And this brings back the same idea of using the team, thinking of all the people that may be more trusted by the individual patient, maybe that they are more likely to listen to. And like I said, never giving up, always keeping that conversation alive.
Well, thank you to both of you. Looks like we're coming up on time. We have time for one more question. I'll look in the chat here. Just as we're waiting for that last question, want to thank everyone for participating today, whether you're watching us live or if you're watching the recording of this in the future. The IDSA Foundation plans to do additional conversations like this, which we call the John G. Bartlett Education Series. And looks like if you would like a copy of the recording, please watch our social media as well as our website for the recording. We would definitely get Scottie's comments embedded into the final recording. So don't worry if you missed that. We'd definitely love to have that perspective of a patient advocate. So to Dr. Dial Hewlett, as well as Dr. Wafaa El-Sadr, thank you so much for your time. Thank you for your generosity, your knowledge, and for doing what you're doing behind the scenes for so many years, right there on the front lines as well, to change patient health and in your communities and your surrounding across the globe, as Dr. El-Sadr was saying as well. So thank you both very much. Have a great day, and we'll see you at our next presentation.
Thank you.
Thank you.
Thank you all.
Pleasure.
Bye.
Thank you.
It's a pleasure. Bye.
Thank you. As we've been discussing, HIV/AIDS has been a part of our lives for more than 40 years now. And for me personally, I have been living with it for 32 of those years. I am here to just share a little bit of my story of how I came to be infected and learned how I was so, and what I've done since in the last 30 years now. I grew up on a very rural farm in Tennessee, and it was a place where I was sheltered and lived a very simple life, but a good life. But it left me kind of unprepared, I think, for the real world just beyond the county line. It was in 1989 that I met someone who would change my life forever. And it was then when I became infected with HIV. The person I had met lived in Nashville at the time, and which was about 100 miles from where I lived at the time. And but he and I, we went on to date for about 3 months, on into mid-January of 1990. And my case has been referred to as a homegrown case of HIV, in that I became infected within 100 miles or so of home. And at the time, a lot of people from the small towns had moved away to large cities, and then would move back home to the little small towns when they were dying, to be close to their families. And with me, I lived in the small town and stayed there. And but nonetheless, mine's referred to as a homegrown case. So in 1989 is when I became infected. I believe, it was through this an unprotected sex encounter with this fellow that I had met, and he and I discussed HIV at the time before we did anything, and he had told me that he was not infected, and I had previously had an HIV test and it came back negative. So without going into all the details, we participated in unprotected sex, and it was, like I say there, that I believe that I became infected with HIV. Like I said, we dated from October of 1989 into January of 1990, and it was a short-lived fling, and but in February, after the I won't call it a relationship, but after it ended, I ended up in the hospital in my little hometown for 3 days with what the doctor would call a major ear infection. I was having flu-like symptoms, and it was a really rough 3 days for me. I was running fever and just couldn't figure out what was going on other than, so the doctor ended up just saying it was a really bad ear infection, and they left it at that. We didn't talk about HIV or AIDS. There was no questioning it. I didn't give any information, but in the back of my mind, I think that looking back on it, I think maybe that I thought maybe it could be HIV. Maybe something had, with what the fella had told me, was just not right, and maybe it was HIV. But I got better, and life went on, and I just kind of put it in the back of my mind. So flashing forward to 1991, in the spring of that year, I began to start having what appeared to be little tiny blood blisters, or bruises, I guess you would call them, appear on my upper body and on my arms, and they would be there for a few days, disappear, and then a few days later the whole cycle would run again. So and this went on from all throughout the spring into the summer and into the fall of that year. And finally I'd had enough, and one afternoon after work I decided I was going to the next county over to a walk-in health clinic and see if we could figure out what was going on. When I first walked in, the doctor, his first impression was that he thought it was leukemia, just from the symptoms that I was presenting, and he wanted me to be seen by an oncologist. So he set me up an appointment for the next day, and from there, the next day, I went down to Nashville, which again was about 100 miles one way, and it was there that I started to get some answers about the little bruises that were appearing on my body, and it turned out to be a condition called ITP. But we also discussed HIV, because the condition that I had could be caused by HIV. So, in discussing my sexual history, the doctor wanted to know if I would be okay with doing an HIV test, and which I was. I felt like there was, just to rule it out, we would go ahead and do it. But it would be a week later before I would get my results. So a week later, while I was at work, I got a phone call, and when I answered the phone, the voice on the other end immediately said, your HIV test has come back positive. You have 5, maybe 7 years to live. I suggest you find a doctor who will treat you. And just kind of left it at that. No referrals, no, just kind of left me hanging. So at that point, it seemed like everything started to turn in slow motion, and I didn't know where I was going to turn or what I was going to do. But luckily, there in the same the next county over, there was an HIV director through the health department who I got connected with, and she got me connected with Vanderbilt Hospital with an infectious disease doctor there, and we began the process of getting me into treatment. The first treatment that I had was the only drug that was available at that time, and I started my first treatment on Christmas Eve 1991, the only drug that was available at that time. I figured, what did I have to lose? So I took it just to, I wanted to keep myself alive. So I also got involved in a support group through the health department, and it was here that I began to see HIV in its reality, I guess, because there were people in varying stages of the illness there, and there was one fellow by the name of Steve that I became really good friends with, and he and I began to talk about that we wish that someone would go public with their status, just to show people in the rural areas that HIV was there. And sadly, he passed away in June of 1994. So it was after his passing that I thought about it a lot, and then on World AIDS Day in 1994, I made the announcement that I was living with HIV. I was the first person to do so in the rural area in which I lived, and I did it just to put a face to HIV/AIDS, and I wanted to use my story to educate others, and that's exactly what I've done over the past 27 years now, sharing my story, talking about the treatment options and that sort of thing. I'm a resource for newly diagnosed persons, and it put me out there as the living, breathing, talking face of AIDS, and I became known as the rural face of AIDS. So over the past 27 years, I have gone out and shared my story with various groups and organizations, and just use it as an educational tool, and hopefully trying to make a difference about HIV/AIDS, because in the rural areas, even today, there's still a lot of stigma attached to it. And I think when someone actually living with the virus like I am, when other people can see me out in the community and being able to talk about it, live openly with it as I do, I think it makes a huge difference in ridding a lot of the stigma that's still out there, unfortunately. But I want to, that's basically my story in a quick nutshell, but I want to end with something that my friend Steve, he wrote me a letter just a short time before he passed away, and he ended it with something that has stuck with me all these years. Like I say, he passed away in 1994. But he wrote, "Never lose hope for a cure, my friend. Perhaps someday we will be able to look back on AIDS as just a very bad memory." And hopefully what he wrote is true. I mean, I've been living with it for 32 years, and there's been so many people who have passed away that I have known personally. And hopefully what I'm doing is making a difference. I know it's made a difference for myself. So thank you for allowing me to be a part of the presentation as a voice for myself and for all those that have been taken far too soon by HIV/AIDS. Thank you.